Hello, everyone. I'm Michelle. In case you haven't met me, I'll just get my computer all set up so I can share my screen. And let me get this going. Okay. I'm just going to share this screen here. I'm hoping that you can all see that. It should say tutorial week 1, part 1.
Yep.
Yep, excellent. What's the time? I got here a little bit early just to make sure it's working and it's recording. It did say it was recording. I can't see that it's doing that, but I'm assuming that it is. How are you going with starting term 2? Okay. Radio silence.
There's a lot of content.
There is a lot of content in this unit, yeah.
I actually did want to ask with the textbooks. So the prescribed one of the sectional anatomy, and then the other one. Do we need to get the other one as well?
The workbook.
No. The one where you're recommending we read chapter 6 from clinically orientated anatomy.
No, we used to use that one. No, basically, and that's what I was going to go over here is your approach to this unit, because it is huge.
Yes.
And that's because the design of the human body is very complex, and we have to understand that because we have to image it all. And so, so we do need to cover everything. We need to show to our external accrediting body that we cover everything, because you don't, past year 1, you don't have another unit that covers anatomy. It's sort of assumed knowledge. You will revise it in each individual unit, but this is where we explore it. This is where we cover it. So the lectures will give you some knowledge, but you don't sit there and write down word for word what I say in the lectures, because you will go mad. They provide information, and then in this tutorial and the study group that we have on Tuesdays and Thursdays, I will cover the most pertinent and important information that you need to know and how you need to think about things. And so these sessions will prepare you for your assessment, because your assessments are designed to make sure that you're covering the most important anatomy and way to think about things that you will use in your profession. So the way to have it is this book, this sectional anatomy book, gives you a really, it doesn't go into things in a great lot of detail. It sort of gives you an overview. The lectures will go into things and unpack things in detail, but you need to think of how you're going to be assessed in this unit. And it's open book assessments, but I will get to this shortly. The unit's called Relational Anatomy and Image Recognition. So you basically have to be assessed on showing that you understand where structures sit relative to one another, and can you pick them out on medical images. And this text is probably the only text that has medical images, particularly CT and MRI images, that are labelled. That I know you're not becoming a radiographer, but as we do ultrasound, we have to compare the sonographic images to MR, CT, X-ray images and PET scans and all sorts of things. So it's assumed that we have the knowledge to be able to do that as well. And so getting comfortable with looking at those is very important to being a sonographer. And so that's why we have this course, this unit. So you will get PDFs, PowerPoints from these tutorials and study groups, and they will have a more condensed information where we've unpacked how to think about things and what things you need to focus on and learn about. You will get more of an idea by the time you get to about week 3 about how it runs, because week 1 it's just like a deer in headlights sitting there going, this just looks like a lot of information. But by the time we get a couple of weeks in, you get more of a feel of how it runs. You also have the past sessions. They don't start until week 2, but you can go and speak to the students that took it last year, and they can mentor you as well as to how you need to start thinking and how you approach your studies to this unit. There's no easy way. If you, and I sort of said this in the email, if you've gotten through on doing like an hour a week for other units, well done for getting through. It doesn't really equate to success in this unit, unfortunately, and you do need to put a little bit more time into it, because it's not rote learning, and the exams are not just give me a bit of information. The exams are open books, so they have a bit of conceptual thinking and things like that in them. So yeah, if you're thinking, oh, it's open book test, that's easy, I'll just Google things, not going to work out. And I'll just pre-warn everyone now that you will need to engage, particularly with these tutorials and study groups. If you're comfortable with what we've covered in these, you will be well and truly, I absolutely 100% promise you, prepared for your assessment tasks, and will feel comfortable with them. Does that sort of help?
Yes, my other question is, so when you provide the learning guides, would it be pertinent to put notes under the detailed learning objectives?
That's a lot of work. It's probably more think about them. So there's a list of terms in there, and they're more, oh, do I know what that term is? Do I sort of have an idea? I mean, if you need to put some little notes down, you can, but don't write answers as if it's the answer for a test, because that's not the way it's going to happen. Okay. But yeah, if you feel comfortable writing some notes, go ahead. But there's got to be a balance between staying mentally sane when you're studying this unit as well, and you having a life outside university as well. Mm-hmm. And so you've got to get that balance right as well.
Okay.
Yeah. They're a guide, you know, you can nearly use them as a quick reference guide. These are all the things that we've covered. If I haven't mentioned some of them in the tutorial or the study group, it might mean that it was presented, but at this point in time, you know, you're a first year, you're going to definitely encounter those terms, but it may not be the most, if we haven't covered it in these tutorials and study groups, it's additional information, and it's things that you're going to build on as we go through your sonography course. You know, it's got 4 years. So, you get to the end of this, and yeah, you get a very, very good understanding of anatomy, and you will be amazed at the end of this term how much you have actually learned. You would not think it's possible. But there's going to be times where you're going to have to come back and refer to your notes in this unit in other courses down the track, because your brain can only hold so much, let's face it. And it's only once you apply information in other courses that some of the penny starts to drop with some things as well. And we as academics and teachers understand that as well. Any other questions before we start? What's the time? Oh,
there's one in the chat box.
Some in the chat box. Sorry.
I can't see that. I've got 2 screens going. So just, yeah, let me know when there's stuff in the chat. Okay, let me think. I think I saw in the intro video we aren't going to be examined on definitions. Generally, yeah. I am not a fan of someone giving me a formal definition because you're not yet, it doesn't really show your depth of understanding. That's more rote learning. And this unit is more not so much rote learning, but getting you to understand and transfer knowledge. Think, I know where this structure, I know what this structure is. Where does this structure sit in the body relative to other structures, and what other structures do I need to know that sit around it? And so questions will be more like that. There's a lot of image viewing questions. So for your online quiz 1 and 2, which are in week 4 and 6, they're more just looking at medical images and saying what structures sit in them. And that's because you're not going to be having your head around everything and all of the terms at that point. And I understand that. So I sort of scaffold up your understanding as we go through. And then when we get to week 9, there's some little short answer questions and you need to type answers in. But again, that's quite a bit of looking at medical images and saying, I know what that structure is off a medical image. And then by the time you get to your final test, there's maybe describe where this structure sits relative to another structure, picking more things out of medical images and using more of your relative terms. So
it's more about the logistics of where everything is rather than this does this and will make this sort of diagnosis happen.
Yes, definitely, because you haven't even learnt pathology and injuries and things like that yet. So before you can start putting a probe on someone's, say, tummy and knowing, oh, I need to look at their hepatic veins, I'm down at their belly button, I need to move the probe towards their head because I know that's where the hepatic veins sit. You need to know what these structures are and where to move the probe and where you're going to find them and have an idea of that you're familiar of even seeing some images before. And so that's why we have to do anatomy now. Yeah.
So just knowing what you're looking at and where to find them in all sort of angles and stuff. Yeah,
you will develop that. Do you have a list of suggested draw it to know it tutorials? I'll quickly go through that today. I've just taken some snips of it so we can even delve in there and have a look at that. So I've got a little slide to remind myself to go over that. So I will go over that, Brian. And is reading the required chapter for sectional anatomy each week enough? The sectional anatomy lecture, the text that you have in this textbook is not, like, it's not a lot, but it sort of assumes that you know what those structures are to a degree. Like, anatomy is like learning another language. And I will try and unpack why some of the structures are called what they're called. But it really is like developing a whole new vocabulary. And so sometimes you'll read it and you'll just be like, I have no idea what that sentence said because I don't know what those structures are. And that's where you might need to refer to the lectures. Or sometimes you just might be totally confused and think, I'm just going to look at some of these terms and then I'm going to attend the tutorial and study group and hopefully get my head around it a little bit more. The pelvis, we're sort of easing our way into it. By the time you get to the abdomen, you really will need to have looked at the lectures because it becomes a little bit more full on. And that's because when you get to year 2, in term 1, you do a theory subject called abdominal ultrasound. And it's just expected that everything in the abdomen, the anatomy, you understand that. You won't really do the pelvis until about term 2, year 2. So this will be looking at some of this anatomy and making sure you've got good notes and storing it away until you use it back then. So it's really how you learn as to whether you're going to use the textbook and whether it resonates with you. I appreciate that everyone's different learners. Some people like to read, some people are tactile, some people are audio, some people are visual. I've tried to put a whole lot of different learning resources in here to tackle everyone's different learning styles. So if there's some part that's not working for you, you know, aim more or focus more on the types of learning that does. Do we need the more textbook? No. If you've got it, it's good because it will give you a different explanation, but no, you don't need that. This sectional anatomy text will be really helpful for you sitting and going through images and picking out the structures. And just by doing that, you get an idea of what's right, what's left, what's anterior, what's posterior, what's superior or inferior on an image. And I'll go through that shortly as well. What sort of notes should we recommend we take from the textbook? I think the textbook's good to read. You're going to have images to label, and that's a really important activity for you to do because that's what is going to be some of your assessment tasks, is seeing an image and feeling comfortable looking at it and thinking, can I pick out the names of the structures? And that's where your textbook is going to become very handy in helping you identifying the structures. I've got quite a few snips in the PowerPoints that will pull out important images, and then you might find going back to the text and sitting there and working through it may help you as well. Has that answered all the questions so far?
Yes, thank you.
Did everyone get the email that I said? It was long, but did everyone get that yesterday? Because if someone didn't get that email, if someone didn't get that email, you need to check your settings and make sure that you're getting emails from your lecturers for your units. In this unit, I like to be equitable. So if someone sends in some sort of a question, I will share the answer with everyone because I think that's fair. And so I will put it either on, send out an email to everyone, or I will make posts in either the Q&A or the discussion forum. I think sharing and don't be afraid to ask a question, because if you're thinking of that question, there's going to be probably at least 40 other people, and I promise you it would be 40 that were thinking, thank goodness someone asked that question, because, you know, there is never a silly question in this unit. And sometimes it's like a sinusoidal wave, learning this and learning ultrasound. One day you've got your understanding, and the next day you come back and you think, I understood it yesterday, but now I'm completely confused. And that's because we're doing three-dimensional learning, and that happens. You get it, and then it goes, and then you get it again. And so you might be in the dip or the trough of your understanding, and one of your peers may be in the I get it, and they can explain it to you, and you're like, oh, I just needed someone to explain it differently, or someone to put a different spin on it. So never feel that, you know, if you're having a point of not understanding, that it's you know, it's no reflection on you. We all go through those cycles, and that's completely normal. So never fear in asking a question, and please do.
I do have one question regarding the Complete Anatomy program that we're using.
Yep.
It says what course you're doing, and it comes up with radiology or radiography, not sonography. So which one would be better for us? There was no sonography option.
That's weird, isn't it? Because I was the one that, has anyone picked one? I probably would have thought radiology, because we want all of the information. Has anyone else had that problem? I don't have that when I go into it, that's all.
Yeah, when I signed up, it asked which one to pick, and I picked radiology because I thought that would be the closest.
Yeah.
I don't think it necessarily changes what sort of content you get. I'm pretty sure it's more just for them to collect data on who their audience is.
Yeah, I didn't get that. So I don't think it should affect what you're seeing, because everyone should have the same access to what the university, we buy a license so that you can use it. And yeah, it really does help. And we'll open it up and have a play and see if yours looks the same as mine, which it should, but we'll do that today.
Thank you.
I think I've covered this approach to this unit already. Watching the lectures, sort of just watch them, don't take a million notes, watch them, hear some of the names. It's sort of like what you do as pre-reading, but you're going to have it in a lecture form before you attend these tutorials and study groups. You want to have some sort of understanding of what we're talking about, or else you're just going to sit there getting overwhelmed. But try and go, I'm not going to remember everything, and be, you know, I will try and guide you and tell you the main important things and the main things that you need to understand. And I simplify it quite a lot down in these tutorials and study groups, and I promise you that will happen. As I said, this unit is relational anatomy and image recognition. So this is understanding where structures sit relative to one another. Does a structure sit more superficial or deep or anterior or posterior, or is it more lateral or medial? Is it more, you could even say, closer to the midline? Those sort of, is it more towards the head? cephalically or superiorly or inferior. And when we get to our limbs, we tend to say more proximal and distal as well. So those terms shouldn't be foreign to you, and I'm hoping that you covered those. You have covered those in other units, and you covered that last term as well. So what I'm hoping that you have coming into this unit is that you understand the different types of imaging modalities. We're going to look at images, x-rays, we call them radiographs or x-rays. So that's a radiograph or an x-ray, an anterior posterior radiograph of the pelvis. CT, computed tomography scans. This is a computed tomography scan. This is an axial of the pelvis. And can you see that the bones are bright or white on the CT scan and they're white on the radiograph? Can everyone see that? Why are the bones white on the x-rays and the CT scans?
Is it because they reflect more of the image back, or they don't absorb as much of the...
No, so we're going to use the term reflection when we talk about sound waves, and that's got to do with ultrasound. Both x-rays and CT scans are acquired with x-rays. This is just an x-ray going straight through the body, and this is an x-ray beam that goes in a circle and takes slices. And x-rays are attenuated by structures of different density. And so basically the x-ray is going through the body and it goes through, we'll see there's nothing here between the two legs and it's black. So nothing has absorbed the x-ray. It goes straight through to the detection plate and it's completely black. It completely blackens it out. When the x-ray goes through bone, the bone is dense and it absorbs the x-ray, and no x-rays get through, or there's much less x-ray getting through to be detected down to the detection plate deep to that. So it shows up white on the image. Does that make sense?
Yes, thanks.
And then we have MRIs. So MRIs are acquired by putting a patient into a large magnetic field. And then when they're in that magnetic field, we apply energy in the terms of radio waves, so what we call radio frequency pulses. And those radio frequency pulses change. They're really going to detect water molecules, basically, to put it nice and simply. And so they're looking for, is there signal or no signal? And so in the bone marrow, we can see that there's a little bit of signal, and we can see bones as these areas. And we have different types of sequences, we call them in MR. And so on some MR images, the bones will be brighter, on some they'll be a bit darker, but it's more understanding the patterns of where the bones sit. But you can see that the bones are not as white as they are on a CT scan or as an X-ray. Can everyone see that? Most of the positioning is done with our patients supine, lying on their back. Occasionally we do imaging of the patient prone, lying on their tummy. In ultrasound, we can stand the patient up or sit the patient up, so we would call that erect, and sometimes we can have them in oblique positions as well. But generally speaking, when most patients have a CT or an MRI scan, they're going to be supine, and most of the time with ultrasound, they're going to be supine as well. With the relative terminology that I've used here, we will go over it, and I will, every time we look at an image, I'll say, let's orientate ourselves first, and we'll work out what we're looking at on an image. And are you okay with the imaging planes? What imaging plane would you say this image of a pelvis is here?
Coronal.
Coronal. So it's sort of an image through showing through the front and back sections of the body. So it's sort of like this, like as you're looking at the the body facing towards you is a coronal section. What section is this here?
Transverse.
Yeah, transverse or axial. We can use either of those planes. Yep. And this one here, this is the spine down here that we're seeing. This is an image of the pelvis. This is
sagittal.
Yeah, this is a sagittal, and this is really what we call a mid-sagittal because it's right through the midline of the body. So we've got mid-sagittal and parasagittal. Para meaning parallel to the mid-sagittal, but not right in the middle of the body. There's some additional lectures in week 1 if you need those. So they're under additional resources in Moodle, and you'll see that Moodle set out the Moodle unit site has a similar format for each week. So there's usually lectures, lecture material has the PDFs, then there's tutorials where you've come to link with this. There's learning activities, that's usually got your quizzes and maybe your Play-Doh modelling and your images to label. And then there's additional resources. And sometimes these just have additional things to help you get a little bit of an extra understanding. I've put a few little videos from Complete Anatomy in here. Just to remind you that you can use them, but you can find them in Complete Anatomy when you go to the videos section as well. And a lot of those are really good. They're only like, 1 to 5 minutes. So they're really short, sharp, and the people on there, there's like some guy with an American accent. He's got a very calming voice. So sometimes when you're a bit overwhelmed, just go to that one. Think, oh, Michelle's driving an ad. I'll go and listen to the calm American guy on Complete Anatomy and he will calm you down. So we're going to do a tutorial today. So this was sort of this pelvis part 1. We're talking about bony anatomy, muscles, ligaments and fascia, and then neurovascular structures. I'll probably get through bony anatomy and muscles probably today in this tutorial, and then we'll come back on Thursday and get through these neurovascular structures. When we talk about neurovascular structures, it's got neuro, meaning nerve, vascular, meaning arteries and veins. So neurovascular structures or neurovascular bundles are usually a vein, an artery and a nerve. Often a lymphatic can accompany that, but we usually don't see the lymphatic channels very well unless they're the really large ones on ultrasound, and sometimes not even on an MR as well. So when we're talking about neurovascular structures or bundles, we often talk about the VAN, the V, A and the N, the vein, the artery and the nerves. Okay, so we've got to unpack the pelvic bones. So, you always see like a diagram of a skeleton, and you can always pick out the pelvis. It's got like these wing-like structures out to the side, and it attaches to the spine and particularly the sacrum in the middle. And it's got these little like sunglasses sort of section down the bottom, which has our obturator, foramen here. And there's 3 different bones. Even though it looks like one continuous bone, there's actually 3 different bones. There's the ilium up the top, which if we draw a line straight through this hip joint area, that's all ilium. And then this top anterior part here is our pubis. And then this bottom, which is actually posterior portion, is our ischium. So there's 3 different components, and we have a right and a left os coxae, they're called. And then this is the sacrum. So you can have multiple different names to describe the bony pelvis, but when we say bony pelvis, we usually mean all of these bones combined, which is a lot of different bones all together. We also have the coccyx down here, which is the bottom part of the spine. This is a 3D formatted CT that shows the bones, and this is an AP radiograph, and you can see they look fairly similar. This is just a more 2D image, and a 3D image reminds you of an elephant skull. Yep, reminds you of a moth. I was going to get an image of a mouse with sunglasses, and I thought, oh, that's probably a bit too abstract on our first tutorial. I'll throw those in later as we go down the week, the weeks of the term. So you're going to get lots of analogies of things. But yes, see what you want to see and relate it to something else so it's easy to remember. And then we're going to take axial views through. This is going to be taken through about this level here, because we can see iliac bones, we can see a bit of the sacrum here. And this view, this axial view, would probably be taken through about this level, because we can see the acetabulum here and the femoral heads here. That would be at about that level.
A quick question.
Was it
Just looking at the diagram on the left compared to the X-ray on the right, the sacrum seems to be a lot larger in the diagram compared to the X-ray. Is that a normal thing, or is that just a diagram to show you it, or do they vary in size that much?
Yeah,
I can see the lot of
quite anatomically correct. It depends on the tilt of the pelvis. So yeah, the pelvis can have different tilts. It can depend on how much fatty tissue is behind here and where it's located as to the tilt of the pelvis when we take that AP X-ray of it. So you will see variations of it. Probably these ones here, we tend to see the coccyx area just down here. And the reason we don't see it very well on an X-ray is there's a whole lot of other soft tissue structures that sit all in here in front of the spine. Does anyone know what sort of might be causing this sort of area on the X-ray?
Bladder.
Yeah, bladder. See these little spotty bits here on this X-ray, and you can see some up here. That's air in the bowel.
Intestines?
Yeah. And so when we used to have to take an X-ray of this, I was a radiographer by background, we just used to call it AP poo because you can't actually see the coccyx when you take a front-on X-ray of it. All you see is poo. So you can only really see it on a side-on X-ray because there's usually a whole lot of poo in the intestines that sits in there. And on the CT, you can see the bladder here, but you'll see a whole lot of bowel. And we'll get to that when we cover more abdomen and intestines more next week. So this picture also doesn't have the femoral heads and the hips. It's just got the bony socket for the femoral head called the acetabulum. I think I've covered that. I just don't know how much you've covered in terms in other units. I usually find that we get a few weeks in and students quite don't understand that we're using similar terminology when we talk about bones as we get to all different areas of the body. So we'll often use the term a fossa. A fossa is like a cup, sort of. So we call this the iliac fossa, and these are like wings. They're sort of round and cup shaped. So see how it's called the iliac fossa? It means that it forms a cup in an area where structures will sit within. A crest is usually an edge of the bone. So this is the iliac crest, these things up here. So when people say put your hands on your hips, it's really putting your hands on your waist. And when you put your hands on your waist and you're squeezing, you'll feel bones. They sort of sit at about your belly button level. So if you run your fingers around the front, you'll feel that these iliac crests here, you'll feel that, and it sort of sits in line with your belly button at this level. And that's where you need to know it sits in your body. So these things are the iliac crests, and lots of muscles, or tendons from the muscles attached to that. When will the tutorial slides be made available? They're made after, because this isn't a lecture, it's a tutorial. And so I'm usually just making them up I was just writing this up just before we started. So, and sometimes if I find mistakes in them, I need to fix that up as well. So unlike your lectures where you're going to get your PDFs at the same time as your lecture, a tutorial where it's supposed to be not so much me talking to you, but you asking questions, then they're given to you after.
What's the difference between the ilium and the ala of ilium?
So the ilium is the name of this bone that extends all the way down here. So all of this is your iliac bone or ilium. The ala of the ilium, the ala is sort of, it can be the same area as well. It's like a wing, or, you know, when someone said it looked like an elephant ear, this whole bit that looks like an ear here is an ala. It's a big, wide, flat bit of bone. So we have a sacral ala, which is this wide, flat bit of bone here of the sacrum, and the iliac ala, which is this wide, flat bit of the ilium there.
So pretty much the upper section.
The more flatty sort of section, yeah. Because where it's flat, not much will attach to it. Things will attach to the edges and these raised irregular bits, but where it's flat, things are just running over the top of it, and it's going to encase things.
Thank you.
We have tuberosities. We'll have tuberosities in our shoulder. We have tuberosities on long bones. They're usually raised bits We'll have like the ischial tuberosity. It sort of sits more down here and at the back, and our hamstrings attached to that. So they're like usually raised, roughed bits where tendons or ligaments attached to. This bit out here on the femur, so that's the head of the femur, the neck of the femur. This is the greater trochanter, and this is the lesser trochanter. See how they're raised outy bits on the bones? And so we have these sort of names. So a whole lot of tendons attached to these trochanters here. And your humerus has what we call tuberosities, where our rotator cuff tendons attached to. Spine, so this thing here, it's sort of like a pointy bit. We have a few pointy bits. This thing is a spine. So lots of different spines. They're pointy bits, things attached to them. So this is going to be what we call our ASIS. We use acronyms. So anterior, superior, iliac spine, because we've got an anterior, inferior iliac spine, and then we've got posterior ones as well. And that thing there is going to be our ischial spine. So you're going to see all of these things labelled in your text, and we will refer to them. We are going to go over these sort of structures again when we do the lower limb, which I think is in week 7. So we will revise this because there's lots of little pointy bits, as you can see. A foramen, you can have foramen in like your skull and a lot of different bones. These are small ones are foramina, so these are our sacral foramina. So I've drawn like nerves come out through these holes. This is the obturator foramen. So there's going to be an obturator nerve that comes through a little canal that's in here. And we have foramen that are formed by muscles and tendons, where usually vessels or nerves or things like that run through foramen. Is the trochanter like a condyle? Yeah, a condyle is usually smaller than a trochanter. Yeah, so we'll have our ulna, we'll have condyles on our radius and ulna, and condyles on our distal part of our femur and our tibia, and they're sort of raised bits where structures will attach. Yeah, maybe a bit smaller. But yeah, sort of similar. Condyles tend to be a little bit more smoother as well. Canals. A canal is usually a smaller thing than a foramen. It can just be a different name. Things will run through them. We're going to talk about the obturator canal, which is a passageway for our obturator neurovascular bundle, our nerve, artery and vein. And then there's notches. So we have sort of notches that are formed. Are you feeling okay with those terms? Any other questions about those?
With the foramen and the foramina, is there an actual size where they change, or is it just your definition of a small compared to a large?
Yeah, don't get too caught up here if you're not using the exact correct terminology your first year. I do all of the marking of all of your assessments, so everything's fair and equitable. And if someone said it was a foramina and it was for foramen, you would still get it right. Over time, you get used to you just get used to the terms that you use for different part of the body. And so foramina can be multiple as well. So it's usually where there's multiple ones. So see how there's multiple in the same bone, whereas there's only one foramen on this side of this bone. So there's a few different things that you get used to using over time. So yeah, don't be too pedantic about having to have it all absolutely correct at this stage.
That's good to know.
As I said, it's like another language. It's like knowing when to use the, the female and the male versions of different languages. And you wouldn't be expected to know that in your introduction, straight off. And people are, can sort of get what you mean. That's fair enough.
So would foramen be used as the plural in a correct sense? So if we said
no, foramen
through, oh, sorry.
Oh, foramen. I think it's sort of like something where you can have plural and singular as the same word.
Okay.
Like lettuce, is lettuce like that? Oh, I can't remember. But don't get too worried about it. Yeah, you don't really say foramen, it's just foramen for one or foramen for two. Two foramen, one foramen. This is you draw it to know it. So you can see this is just a nice little snapshot. It does look like there's a lot of stuff there, but it does help if it's coloured. You can see that they've coloured the 3 different bones, different colours. So you can see this is all your ilium, this is your pubic bone, this is your ischial bone. Can you see that? And then your sacrum's a different colour. It's sort of labelled a few different points on it for you. So it can be a good quick reference guide for you. So you can snip those, like I've just gone in and snipped it, and it does give you some notes if you need to. So that's, and if you end up drawing it and then draw all these little things in, you end up going, oh, I didn't realise that when I looked at it, but now I have to draw these little notchy bits. I can see the different notches and what's a spine and what's the ASIS and what's the AIIS, because they're 2 different things. Anterior superior iliac spine and anterior inferior iliac spine, and then you'll have posterior ones as well. So drawing it can sort of help you understand a few of those intricacies, and we'll certainly be pointing them out when we go through our medical images. Any questions about that? I think what you're going to need to do you want me to show you how I would get into it?
Yes, please.
Okay, so we're going to look for this little skull thing here for probably your growth anatomy. Let me get it up. I think I had it up. Okay.
Is the draw it to know it through complete anatomy?
No, it's a completely separate thing.
Right. That would make sense because I don't have it.
You get to it. Oh, it's expired already. Let me just get back to our Moodle page and I'll show you what I did. Sorry, I've got complete anatomy open. If you have complete anatomy open on your computer, you will notice that it does start to make your computer go a little bit slower. So I think I put it in your learning community tile. So I'm here in the learning community tile, this one, and I'm going down and it's got click here to access draw it to know it. See that? I click on that and then I open it up and it looks different to what it used to look last year. I think we've got a wider license for it. You can either go into this gross anatomy and that would get, so we can click on that and it will get this pelvis up that I got. I think I probably would have gone into muscular system for that. For muscular systems where you're going to have your bones, I would have thought. Didn't do this one, pelvis here. And then I've just gone, oh, that probably doesn't have the bones. Pelvic walls and diaphragm. Not have, would have been in there one. Anyway, let's go to pelvic walls and diaphragm, see if that's got it. It may have changed things. Oh, well, here, you can see that it's got, this is going to be where you're going to get your, there's pelvic girdle, and see how I've hit on pelvic girdle and I've got this image here that's got these things labelled. So you just need to go and have a little play around with it. And then you can sometimes get your notes. And there's a whole lot of notes when you scroll down here, and sometimes it can just explain what it is there for you. The other thing you might want to go into is I found out you can go into this musculoskeletal system here. This is for like if you're looking for bones and things like that. And then we can go into anatomy, and then bones and features, and I think that's just got a general overview, and you can see that there's a whole lot of things, like if you want to go to upper and lower limbs, pelvis, pelvic girdle in here. So that's where it's hidden. It's just changed a little bit. It changes each year. But that's got the same thing. Does that make sense? And see how it says the spine is a small projection. It tells you which way it points. Ischial tuberosity, it's a roughened area where hamstrings attach. A ramus is usually a connecting bit of bone, connects two bits. And then greater sciatic notch will be bounded between this and up here. So that's going to be our greater sciatic notch. And our sciatic nerve will go through there. Does that help?
Sorry, Michelle. So when we're in here and it's got a drawing pad, is that what we're supposed to do? Go onto the drawing pad and then sketch it on there, or are we just sort of doing it on a bit of paper?
Make some notes.
Okay.
Yeah, have a go at that. Have a play around, and if you find something good, post it in the Q&A or discussion forum, and tell people what works. Like so you can draw along with the video. So there's a whole lot of things here. There's even quizzes and exercises and all sorts of things. It's become a little bit more broader than what we had. I think we had a basic version in other years, but the university is quite good at investing some money to get a lot of these active resources, which are really good when you're learning online. Does that help?
Yeah, thank you.
Yeah. Okay. So that's draw it to know it. You may not use it for everything. Probably once we start getting to some organs in the abdomen, it might be a little bit basic, but certainly for your upper and lower limbs, it's going to be helpful. There's a whole lot of different things. So you just need to sort of play and see what you can get. But yeah, if anyone finds anything really helpful, post it. It's good to be, collegiate here, and everyone helps one another. We all learn and become a bit more efficient at things. That's quite helpful. So yeah, I went into the bones and functions and features. There might even be little tutorials that you can watch in there as well. Complete anatomy. Do you want me to show you how well, actually, I'll show you that when we get onto the muscles. I'm watching the time. So once we get onto muscles, I'll open that and even the bones, and we'll have a look at that. I think it'll be easier than playing with this. You've got these notes, so I probably don't need to go through these. This is just the anatomy, and you can see it's demonstrating this part of the os coxae in the pelvic x-ray. So when we do the pelvic x-ray, you can sort of see we lie the patient supine, we take an x-ray through this way and the detection plates underneath. And that's why I was saying some look a little bit different. Some people's pelvises are tilted from side to side. It might be up and down. The feet may be a little bit elevated, and that can change as to where this sacrum is projected. I'm going to slip through here. Everyone understands prone versus supine? Now, the reason I've got this is most of our ultrasound patients will be supine, except for maybe when we're scanning the Achilles tendon. If you don't know where your Achilles are, they're this thing here on the back of your sort of heel, the back of your ankle. It's a tendon. And so we need to roll a patient on their tummy to actually put the probe on that, because it's hard to put the probe on it when they're lying supine like that. When we have the patient lying supine, when we look at an X-ray or a CT scan, this is the right and this is the left. Is everyone okay with that? So the way when you lie your patient down on your bed, this will be the patient's right and this will be the patient's left. Can you see when you look at a person, that's going to be their right side and that's going to be their left side. Does that make sense? So when you look at an X-ray, it's like you're looking at a person facing back, looking at you. So this is their right and this is their left. And when we look at a CT and an MR in axial and coronal planes, this will be the right side of the body and this will be the left side of the body. I cannot stress the importance of starting to say this is a right-sided structure and a left-sided structure, because it's really important, because you're going to, in your assessments, have to say, I might say, what is this structure here? And you're going to have to say, that is the right iliacus muscle, because we have a left one on this same image. That is not just the iliacus muscle, because we have a right and a left iliacus muscle. This is the right greater trochanter. This is the left greater trochanter. When we're seeing both of them on one image, there's two structures there. We have to know, because you're going to end up saying there's something wrong with one of them. You can't say there's an abscess in the iliacus muscle. Which one? We need to treat it. The referring doctor is going to be saying, which one, which side? Sometimes, the patient may not be symptomatic. And so, it has to be, that detail is very important. So understanding your right and your left is very important. Start, every time you look at an image, start to do that. It will really help you as we go down the track. When we turn the patient over, which leg is this?
Left.
The left.
The left. So we get very used to putting our hand on this side of the patient, going, this is the right and this is the left. When we turn people over, it gets really confusing. So you'll have to always go, oh, the patient's prone. This is going to be the left side of the patient's body, and this is going to be the right side of the patient's body. And can you see they're facing away? They're not facing towards us now. And so this is going to be their left, and that's going to be their right. This is going to be their right, and that's going to be their left. It's a bit of a concept thing to get through, but is that making sense?
Yes, thank you.
Yeah.
So this is going to be the right side of the patient and the left. This is actually going to be the right side of the patient, and the left is going to be over here. So this is a supine CT. We hardly ever do prone CT scans. We would generally do this if we're going to be putting a needle into someone. So this is the left side of the patient, and this is the right side of the patient here. Because this patient is prone, because that's their sacrum or spine. Can you sort of see the outline of their buttocks? They're not boobs, that's the bum crease there. See, that's the sacrum there, and then we've rolled the patient over prone, and that's their sacrum. Can you see that? So this is right and this is left when the patient's supine. This is left and this is right when the patient's prone.
Is there any way on the image to know which is which, or is it just to look for that sacral image?
Oh, at your stage, I would definitely be telling you if someone's supine or prone, but it's something that you do need to be aware of, because it's not very common, but it will confuse you, and it's something that you do need to be aware of. So you may get a question and it says this patient is prone, and you go, oh, prone. I've just got to remember my rights and my lefts are around the other way.
When it comes to these sort of MRI scans, or like especially in say the axial or transverse view, are they always going to be from a superior perspective, or can they sometimes be from an inferior perspective as well?
They're always going to be, this is right and this is left when they're supine. It's actually a slice. Yeah, I find that students ask me this, and I've changed my thinking so much that I suppose you're looking, if this is right and left, this would be from the inferior perspective, wouldn't it? Because you're going to be looking up from their feet. Or even if you're looking down, I suppose. But it's sort of a slice, like it's a slice through. It's not looking from one direction or the other, I think.
Yeah, okay.
Hard to explain.
So you don't need to know the top and bottom of that image?
No.
Whether it's inferior or posterior?
Top and bottom, because it's a slice.
Well,
so this
that does
is
make sense.
inferior,
Yeah.
and this is posterior, and this is right, and this is left. And it's a slice of like a 2 millimeter thickness slice. Does that make sense?
Yeah, thank you.
I think I've got it. I'll explain that when we get through, because I'll show you where slices are taken through. Do you think we're looking from a medial or a lateral approach at this?
Lateral.
And how did you know that?
Because of where the head of the femur will sit in that socket.
Yeah, so what we're looking at, this is the socket, and this is where the head of the femur sits. And then when we pull this out, we look in and we can see the socket. So we were looking from the lateral view in this way. Does that make sense? Not that you're ever going to see a pelvis that looks like that, because hopefully someone's always going to have their hip in there. Otherwise it's dislocated out. It's just, I've just got that in there to get you to think of which direction we're looking at things from. Are you fine with the components of the os coxae? This is the big ilium bone. This is the pubis bone, and this is the ischium bone. Is this anterior or is this posterior where I've got my arrow here?
Anterior.
Anterior, because our pubic bone, think pubic hair. Your pubic hair sits more anterior, and your ischium, like where your hamstrings sit, they attach onto this ischial tuberosity, and your hamstrings are in your bum sort of direction. Does that make sense? So pubic tends to be anterior, ischial tends to be bum more posterior, if that helps. That's going to help when you look at an image in axial views, and we're going to look at bones more at the anterior and posterior component, like this. This is more anterior, so they're going to be our pubic bones. These are more posterior. Oh, that's wrong. That shouldn't say ilium. They're going to be our ischium. Can you see that? Is that making sense?
Yeah.
I know it doesn't make sense straight away, and it's not expected to. That's why I'm just going through, let's point these things out. This is still right and this is still left. So in your anatomy text in this book, this one here, you will see there's a little A and a P. So that's to tell you this is anterior and that's posterior, and it should have a right and a left. And when we've got like a coronal image, it should have superior and inferior, and an S and an I on there. And I want you to start looking at an image and saying it's an axial, it's a coronal, or it's a sagittal, and I'm going to get my orientation sorted out. Okay, I'm just going to throw in, I have done some snips for you. So I have got a series of images that are going from superior down to inferior, because that's the way through the body. So from sort of neck down, we will image from superior to inferior. Once we get to the head, it's really confusing. We go from inferior to superior, but generally most of the body, we image from superior to inferior in slices. So these are superior, so we can sort of see lumbar spine, and then we're coming through our iliac crests here. We can see our iliac bones here, and then we're coming down, we can start to see the sacrum posteriorly here. We're going more inferiorly, and we're traveling through the iliac bones. We get to the top of the iliac bones, and then we're starting to come through the acetabulum and the femoral head area here. Can everyone see that? We're going further down. So we started up here and we're traveling slices down this way. And as we come down, then we're going to get bones that sit more anteriorly out here. Which bones will these ones be?
Pubis bones.
Pubic bones. And then there's going to be bones that sit more out here near the buttocks region. See the just a little gap between your two butt cheeks. So what bones are these ones going to be?
The ischium.
Ischium. So see how we've already worked out pubic bones sit anterior, ischial bones sit posterior. We can work out which is our iliac and pubic and ischial bones as we've gone through. So I've given you some series of images when you get the PDFs to go through, and you can sit there and sequentially make your way through. And I find that that's easier than in the text because it doesn't give you these series of images. And when we look at them and when you work in a clinical practice, you will scroll through them and see them like that. Do they sort of help, do you think, seeing a series of images?
I like it. It helps me.
Yes.
So I've once again gone through and snipped a whole lot. It takes forever, but these are sagittal images. So these are going to start laterally and come through from lateral through to midline, and see how you can see we're in midline when we see the spine here. So this is anterior and this is posterior. This is superior and this is inferior on these sagittal images. So it's like a slice through the middle of the body this way. And we've got the lumbar L5 vertebrae. We've got the sacrum. We've got a bit of the coccyx here. This is a bone at the front. What bone do you think that might be?
Pubis.
Pubic bone. That's right. If we go back out more laterally, we can see some bones out here posteriorly, and that's going to be our
Ischium.
Ischium.
So can you see how it's really important to orientate yourself on these images? I think everyone's okay with looking at the sacrum. You can see there's little sacral foramina. They transmit nerves through them. And the coccyx, as I said, AP2, we can't see it, but we can see it on a reformatted CT scan because the bones are white, and we can see the sacrum up here and the coccyx down here. This is called our femoroacetabular joint, or our hip joint. We just call it our hip joint, but anatomically we could call it, because it's the joint or the articulation between the acetabulum, and the acetabulum's made up of the iliac bone, the pubic bone, and the ischium bone. It's where they all join together, and this femoral head sits in it like a little, we call it a ball and socket joint. So the ball is the femoral head and the socket is the acetabulum, the bony acetabulum. And you can see it in an axial view here. Here's your socket of the acetabulum and your femoral head here. And then I've given you some CT scans as well in theory. So I've gone through and snipped all of these. And once again, these are going to run from superior through our lumbar spine area, come down, and then we're going to hit our iliac bone, our iliac bone, our iliac bone. This is the junction between our iliac bone and our sacrum. So this is a joint or an articulation, and the articulation or the joints are named after the two bones that they bring together. So it brings together the sacrum and the iliac bone. So it's called our sacroiliac joint, or what we often call the SI joint. So we have a right one and then we have a left one. See the right one there and the left one there. Can you see those joints don't actually, those bones don't actually touch each other? They're held together by ligaments, and there should be some articular cartilage that sits in there. Can everyone see that?
That middle picture on the bottom looks like a happy little stingray.
Yeah, it does, doesn't it, that one? That's a really good point. Yeah, it's got the eyes and a mouth. What sits in this hole here? Does anyone know?
Is that where your central nervous system runs?
Yeah, so you have, if we come back up, you'll see our vertebrae has a sort of central spinous canal, really, and our nerve roots from our spine. Our spinal cord only goes down to the bottom of our thoracic spine, really. So these are just all nerve roots that emanate from that spine. And then they come out through these little holes here. And then some still come out and they sit through here and they come out through these sacral foramina here. So this is where all of the nerves come through, and then they travel out to the front of the pelvis through these little holes. And then we're coming down, and so the CT pictures are similar to the MR pictures, but can you see that the bones are a lot brighter, and we see the bones a bit more distinctly. We can see at the front, we can see our pubic bones, and then we can see our ischial bones here. We can make out the muscles, and we're going to get to some of those very quickly. Here you can see the sacroiliac joints. It's between the lateral mass or the ala of the sacrum and the iliac bone here. Are there any questions about these?
If you, sorry, Michelle, if you were to be imaging the most superior part of the sacrum, would that be when the happy little stingray appears?
Yeah, it's sort of, so you go through from your L5, then you hit a disc space, your L5S1 disc, and yes, that's the top part of your sacrum right there. That's right. Okay. Yep. So that's the top part of your sacrum, and then we're going more inferiorly, and then you see it get smaller and smaller like this. We still know this is sacrum because there's two little bar bits at the back. That's sacrum. And then from probably this point on, where it becomes more circular, that's going to be coccyx right there.
Yeah.
Yeah.
Thank you.
That probably wraps up our bones. I've probably gone a little bit more slowly through that just so that you can get some concepts. I'm going to pull up anatomy, a complete anatomy shortly, and I don't have too much more to go through. I didn't know if anyone wants to take a little break, a toilet break or anything before we go on to the second part, where we're just going to introduce some muscles and see what they look like on some images. As I said, we sort of ease our way into it in week 1 to get you used to some of these terms and things like that. So you're using the correct terminology and getting a bit of spatial awareness when we're looking at the images. Anyone need a break, or do you want me just to keep going?
I'm good to keep going if anyone else wants to keep going.
Need a break. Remember, I'm sure it is recording. So have a break and you can pick it up in the recording. Mariam's going to take a little break. Have a little break, and you can pick it up. You won't miss too much, but yeah. Once again, you'll know where to come up in. It's in the 1 hour mark of the recording, so you'll know where to come if you've missed anything. That might be easier. Then we don't go over time. There's quite a few muscles in the pelvis, and when you look at it, it seems very overwhelming. I'm going to break it down because there's a couple that I just want you to focus on just this week, and then you'll be like, that's very manageable. I can do that. We start talking about the pelvic floor and the pelvic wall. I'm going to concentrate just today on the pelvic wall. The extra pelvic muscles, we sort of talk about when we can talk about them in other weeks. Is everyone okay before we move on to muscles and tendons and ligaments in understanding what a muscle is? I think everyone knows what a muscle is. It's got like a muscle belly, but muscles have tendons at either end of it. They always have a proximal and a distal attachment, or an origin and insertion, whatever you want to call them. Because muscles don't attach directly to the bones. Sometimes the tendons are very, 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 very short and it looks like they do, but they will always have a tendon at the end. And the tendons are what attach the muscle belly to the bones. Everyone's okay with that concept?
Yeah.
When they do.
Yeah.
Yep. Sometimes we just forget like our very basic stuff, so it's just good to reiterate it. Ligaments, generally, they don't have a muscle belly in them. They're connective tissue like tendons, but they just sort of attach mostly bone to bone. Sometimes they'll attach another ligamentous structure to bone. So ligaments can attach a sort of ligament to bone, so they can blend with other ligaments as well. But ligaments generally sit over, these ones aren't sitting over a joint, but they can attach 2 different bones to one another, if that makes sense. Sometimes they can attach the one bone to each other. They don't really do too much, but they allow a bit of movement between bones, ligaments. They're often at joints. Does that make sense? Hopefully. Where the bone, the ligaments and the tendons attach to the bone, like there's going to be a transition from the ligament and the tendon to the bone. And that transition we call the enthesis. Have you come across that term?
No, not yet.
No, me neither.
We're not going to talk about it too much. We certainly look at these entheses. Entheses is the plural of enthesis with ultrasound, because we see really small structures. In what we're talking about at this level, we're not going to use that term enthesis. I might refer to it slightly, but it's just where the tendon or the ligament attaches at the bone. That's the enthesis. Likewise, where the tendon attaches to the muscle belly, that transition zone between tendon and muscle is called a myotendinous or musculotendinous junction. And we often refer to that as the MTJ. So myo means muscle. So think of a myocardial infarction. It's like where a bit of your heart muscle doesn't get blood flow. So we use these big long terms, but it's really got myo, which is muscle, cardio, which means heart, infarction means no blood supply. So you end up with this big term, but you've got to know how to break those terms down. Am I starting to sound foreign, or is it okay? Are you following?
It's okay, but can you just say what the MTJ is again?
It can either be myotendinous junction or musculotendinous junction. Either of those terms you can use. In anatomy, there can often be multiple terms that mean the same thing. And it's very frustrating as a student because you're like, I've been referring to this thing and I didn't realize it was the same as this thing. But we're going to come across that in a lot of different areas. So either myotendinous junction or musculotendinous junction, because those words are so long and sometimes you have to write them out, you just write MTJ because it's much faster. So we do use a lot of acronyms just because the anatomical terms can get so long. Still following?
Yeah. Yeah.
Yes, thanks.
So when we look at the pelvis, if we pretend we're in the midline of the pelvis and we're looking out to the sort of walls of the inner pelvic basin, there's just two main muscles that I want you to appreciate. One's called the piriformis, this one, and one's called the obturator internus muscle, this one. They make up what we call the lateral or side walls of the pelvic basin. These ones here are more central and form a cup, and they're going to form more of the pelvic floor. So we have the pelvic floor muscles, and then we have the lateral wall muscles. Is that making sense?
Yes, thank you.
So there's two muscles, the piriformis and this obturator internus. Where have we seen this obturator word?
Obturator foramen.
So that's actually this thing, and it sits over the top of it, but it sits internally and it faces your pelvic organs, really, is what it means by internus. And the piriformis will line the back sort of lateral part of the wall of the pelvis, and it also sits a bit more superior relative to this obturator internus. So I'm starting to mention some relative terms here. Where do these muscles sit relative to other things, and where do they sit so you could describe their relationship to other structures? So let's unpack. So what I did is I got an X-ray and I thought, okay, you think you're okay with that. You've got the iliac bone, you've got the pubic bone, which is more anterior, and you've got the ischium bone, which is more posterior, because you can't really appreciate that from the X-ray. And then I sort of very dodgily, sorry, a lot of my drawings are dodgy, but I drew in where your piriformis muscle would sit and where your obturator internus muscle can sit. So how would you describe where your piriformis muscle sits relative to your obturator internus muscle?
Superior?
Yeah, because it's closer to the head, isn't it?
Yeah.
So it's definitely superior. And so when we look at our axial slices, and they're going to come down from superior to inferior, are we going to see the piriformis muscle first or the obturator internus muscle first?
The piriformis muscle.
So can you see this is sort of looking from like the back view in complete anatomy of it, and you can see this is the iliac crest, this is towards the head, and this is the ischial tuberosity, it's more posterior and more towards the feet, and you can see the piriformis sort of attaches to this lateral wall of the sacrum, and then it comes through the greater sciatic notch, which is this thing, and then it runs posteriorly and it's going to attach onto this thing. What's this bit of bone here called?
Greater trochanter.
The greater trochanter of the femur. And in particular, is this our right or our left?
Right.
Okay, excellent. And then we've got the obturator internus muscle. See how I've sort of drawn it sitting over the obturator foramen, but it's going to sit inside the pelvic basin, and then it's going to emanate with this skinny little tendon. So you can see the muscle belly's maroon color, and the tendon's white color here. And then it travels posteriorly, and it also attaches onto this back or posterior part of the greater trochanter. Can everyone see that?
Yeah, thank you.
Okay.
With that description, would it be superiorly and laterally to the obturator internus then?
Not lateral, because it also has a medial component here.
Okay. Yeah.
Yeah. So sometimes you've got to be careful of the words that you're using to best describe it. So I will open up complete anatomy and we will have a look at these things. We also have these things. They don't have any muscle bellies within them. What do you think these things are? They're just white the whole way through.
Ligaments.
They're going to be ligaments. And see how they're attaching a bit of bone down to another bit of bone and a bit of bone over to bone. And so they're ligaments. They don't have any muscle belly in them. They look sort of similar in colour to these tendons, but these tendons attach to a muscle. Can everyone see the difference between a ligament and a tendon there?
Yes.
I just went into complete anatomy before, and it does get a bit confusing because it overlays a lot of muscle. So if anyone finds out how we can separate these out, I know I've done it in the past, I just can't quite remember how I did it. This is looking from a posterior view, and you can sort of see that you see this piriformis again more posteriorly, and that's going to be an interesting concept because it attaches more to the front part of the sacrum, but then it comes out through this pelvis and it runs over to this greater tuberosity, greater trochanter area. So it runs from medial to lateral as it goes through. Oh, you can change the amount of muscle layers. Oh, okay, that's really good. I might do that. I've changed that. We'll have a look at some medical images. Yeah.
You can actually select like only the muscles that you want to show. So if you only want to show the piriformis and the obturator internus, you can actually click on those and then click up the top. It'll be the top left hand and hide the rest, and it'll keep just those muscles in the skeleton there.
Oh, I know I've done it before. I just couldn't remember this morning what I was doing. Thank you. That's great. So this is an axial, is it an MR or a CT? Who wants to have a go at saying what type of an image that is? Oh, I've given it away. I've got the name of it down here. Sorry, that's an MR and this is a CT. Can you see the bones are white in the CT scan? The piriformis muscle is sort of sitting between the sacrum and the iliac bone. Can you see it sort of sitting in here and here? And it's going to sit in here and here because it runs between, can you see it's running between the sacrum and it goes over the iliac bone, and then the tendon's going to be quite small as it comes down. And you can see it doesn't run in a complete flat angle. It sort of runs in a superior to inferior orientation as it runs from medial to lateral here. So we're seeing most of the muscle belly here, but we'd have to go down some slices until we saw the greater trochanter to see the distal part of it just there. But the important part of picking it out is that you're going to see iliac bone and you're going to see sacrum and you're going to see a muscle sitting between those. So here's our sacrum, still have iliac bones because we know we're above the level of the acetabulum, and then we've got our piriformis muscle sitting just in here, which is through here. Can everyone sort of see that? Can you see how it sort of hurts the brain a little bit to think about it? Why is the piriformis an important muscle that we know about? Have you heard about people having sciatica? You go, I've got sciatica, I've got sciatic pain.
Yeah, when I was pregnant.
Yeah, I've had it.
We have a big nerve called the sciatic nerve. And it runs in close proximity to this piriformis muscle. And so it sort of runs from the spine, it comes out, and then it runs anterior to the piriformis muscle, And then once it gets to the bottom level of the piriformis muscle, it's then going to run posterior to a whole lot of other muscles down the back here. So it's like a little exit point of the pelvis at the inferior margin of the piriformis muscle. And sometimes people can do exercises and they can really make their piriformis muscles quite big. And I don't know what exercise that is. I'm not a sports person, but occasionally that nerve can get a little bit compressed as it comes out underneath that piriformis muscle. So we have to image it, and sometimes we might need to do injections around it at that point. And so that's why that piriformis, it's called piriformis syndrome. It is an important muscle for us to appreciate. You can get sciatic pain for all different reasons. That's an unusual form of it, but yeah, that's why understanding about that piriformis muscle is important. So let's try and find our piriformis muscle as we scan through. So here's our iliac bones, here's our sacrum. It's going to sit just in here and just in here. And then we're going to see the distal portion of it just here. And then by the time we've gotten down to this view, we've sort of lost the piriformis. But by the time we get down to this view, we're inferior to the piriformis, and there's a muscle that sits in here that's lining the inside of sort of what's going to be the obturator foramen area. Can you see this bit of muscle just here and this bit of muscle just here? And as I go down, this muscle just here. Can everyone see that?
Is that the obturator internus?
Yeah, that's going to be our, see how it's internal, like it's near the pelvic organs as well. See how this piriformis is near, this is all bowel and pelvic organs in here, but see how it's lining this lateral wall of the internal pelvic basin, and so does this one here. It sort of lines, we're going to have our bladder here. I'm not quite sure, I think we've got a female here, it's hard to tell. Yeah, that's a female. But it's lining the inside part of the pelvis down here, down here, down here, and it's going to sit down here, and that's going to be our obturator internus muscle. And so we need to know that we're going to see our piriformis muscle superiorly, and then we're going to go down slices and we're going to see our obturator internus muscle inferior to that. And so we've already developed in our thoughts, when we see a series of images, I know when I'm up at this level, I think piriformis. As I move down, I think obturator internus muscle. Can you see how where you know where they sit helps you to interpret a series of images like this? Sort of.
Yeah, it does make it easier now that you know what you're pinpointing.
Yeah. And
do those muscles change shape or size in different people, or are they always very similar?
No, they can change. And as people get older and don't use them, they what we call atrophy. So they become smaller. You've heard of muscle wastage. So older people just get muscle wastage just because they're not using them as much. And so in sporty people where they're using certain muscles, their muscles will get bigger. When they're not used, they will be smaller. So they can vary in size on different people. And you just look at someone and think, gee, they've got big calf muscles, and their calf muscles will be bigger than someone else's calf muscles. It's the same for any muscles.
I feel like most of the time that a scan like this would be done, the person would be relaxing their muscles, but would a tensed muscle look very different?
It probably has a different shape. But yeah, most people are, I suppose if they're having contrast injection, they might tense their butt muscles and it might make them have a different shape. I've never thought of that. That's a very interesting point. Yeah, I'm not quite sure. That could be your fourth year research assignment project. There, write that one down. It would be a really good topic.
Does that mean we get to stab people with needles?
Oh, you wouldn't be stabbing these muscles. They're fairly deep. Not for your research assignment. You're not stabbing people with needles either. But you can look at them on imaging and look at the size. And you could do a study where you looked at someone clenching their muscles and relaxing their muscles and see if it did look different. Yeah, interesting. So here, getting to know your pattern recognition Can you see your femoral heads? Do you think they're nice and easy to recognise on this image? They're probably the thing that stick out to me on this
Are they
image.
always so round?
Yeah, unless there's something wrong with them. If someone's, well, if they've been dislocated out, or sometimes kids, so we do ultrasound on pediatric hips and they can have a bit of a flattened head, or if this acetabulum's not deep enough, they will dislocate or sublux out. So some people can have problems with them, but on people that are normal and healthy, they should be this round always. Yeah.
Cool, thank you.
So you can see the femur and you can see the acetabulum, and then you move immediately medial to the acetabulum, and what do we see? The obturator internus, right and the left obturator internus muscle. So do you see how learning anatomy is a bit like pattern recognition? At that level, when I'm looking at this structure and medial to this bone on the inner lining of the pelvis, I'm going to see, and these are, maybe this one was clean. Who knows? Let's just have a little quick play with a complete anatomy. I've got it open because I was playing with it before I started. And this is where I was, and it'll probably be slow because I'm recording. So we can rotate this around. I can take the muscle layers off. Now, how do I just show this muscle if I want to, and I want to take the other muscles off?
So on the left-hand side, see how it says hide others or fade others?
Fade others. Oh no, I think we just need to hide the others. Oh. Can we bring the bones back?
So first you've got to have the bones there, and then I usually just search for the muscle and do it that way, and then it shows you that muscle on the bone, and then you can...
Okay. Let's do that. So we'll take our muscle
Sometimes
layers.
it's quicker that way.
Yeah. Let's have a look. We'll take them all off, and let's just rotate our bones through, since everyone's feeling okay with the bones here. So when I rotate it this way, you can see that these muscles are going to sit sort of lining the inside of the basin of the pelvis. So can you see the wings, the iliac wings? They're nice and flat and nothing really attaches to those. And see when I change the tilt of the pelvis, how the sacrum position changes. Do you see what I mean there with the tilt of the pelvis? How in some APs it's going to look like that, and then some AP views it's going to look like that. It's going to depend on the tilt of the pelvis of the patient that's lying there, and their lie. So this is sacrum and this is coccyx. And then even if I add on nerves and I add them in, can you see the nerves come through these little foramina here? And then if I turn that around, yeah, they're going to sit in the back in that spinal canal through there, and then they're going to come through here, and then they're going to help to form this big nerve. What do you think this big nerve that's going down the back of the leg is going to be?
Sciatic nerve.
Yeah, and if you're not sure on complete anatomy, you can just click on it. Oh, it's very slow. Sciatic nerve. So see, when you're learning, you go, I don't know what that is. Oh, I'll just click on it and it tells me straight away. Like, it's much quicker than you looking things up in a book and working things out. So then if I was to add on my muscular layers, I don't know how I'm going to do this, but...
If you just search on the right-hand side, if you just search piriformis.
Oh, okay.
So if you take muscles off and then search piriformis,
Okay.
it'll put just that muscle on, and then you can do another search and put another muscle on.
This is excellent. You can take the next one. Oh, sorry, it's really slow. I'm piriformis. Sorry, I'm typing, but it's not coming up. So piriformis, maybe I should have just put muscle.
Just under muscular system.
Here we are. Okay, so can you see, just wait for that to go. It just is going slowly because I've got Zoom and recordings going. Can you see that it's going to sit anterior to the piriformis, and then below it, it's actually, if I can add on some other muscles here, and you're going to see that it's, going to sit superficial. So there's the piriformis. It sits anterior, the sciatic nerve sits anterior to that, and then it sits posterior to all these other muscles. Can everyone see? So it emerges between the piriformis and this other muscle here, our superior gemelli muscle. Then we've got this, which will probably be our obturator internus muscle just here. And can you see, so it sits posterior to this obturator internus, but anterior to the piriformis, the sciatic nerve. And see how, like, that's where we're talking about the relationships of structures. And so here you can see that piriformis muscle, which is this one, sits superior to our obturator internus muscle as well. So can you see when you're using this, don't just find out what the muscles are, but you're going to see where they sit relative to others. And then on the study group session, we're going to play around with some of these, which are going to be our levator ani muscles. So that's going to be our coccygeus and our iliococcygeus muscles and things like that. And you can just click on them and it can tell what they are. So you get a nice quick feedback when you're learning, and you start to go, okay, I'm going to look at them from superior to inferior, and then I'm going to turn it around and see where muscles sit. Sorry, it's just going slow. It's just locked. Won't move it all. There we are. So we can take some muscle layers off there. Yeah. So if I just take all of them off, and then you can add like obturator internus on. So we'll take our nervous layers off as well. And this is going to be good when you look at some of, like, we look at our obturator nerve and think. The only thing I found is it's hard because that whole thorax comes over the top, but our obturator internus, see your obturator foramen just here, it's going to line that. So let's add that on.
You can cut it from the hip, like from the hip or from like the L4 or L5, so that that's not in the way as well.
Oh, excellent. I've obviously had more of a...
I used it a lot in my anatomy last year.
Oh, okay. Obturator internus muscle. Oh, I've left. Let's put the right one on. Oh, well, that's the left. See how it... Oh. See how it's lined over, but it's left a tiny little hole here. So it covers most of that obturator foramen, but it leaves a little hole, and that's where a nerve is going to sit, just in there. So if we, and the nerve that goes through there is going to be our obturator nerve. And that's just because it's going to run through that, that little obturator canal. It's really slow. It'll be faster when you guys do it. It's probably just frustrating watching me. Obturator. Nerve. See, there's a little nerve, and see how it comes right through this little hole here. And so there's an obturator foramen, and then there's an obturator canal. We'll go over that next week, but that's going to be important that you have a look at that. Does everyone feel like they can have a decent play? I mean, you can't do anything too wrong with it, but see how the nerve is going to run through? Where would you describe where that obturator canal sits relative to the obturator internus muscle? What aspect of the muscle does it sit within?
Anterior.
Anterior aspect. That's right. Okay. I will shut that back down. I'll let you have a play with that. The girls that run the past sessions, they're going to go through that with you as well. So probably more in the tutorials and the study groups, I'll go through helping you understand things, and then they will play with that with you. They're going to go through the images to label with you. So once you've done these tutorials and study groups, you go and have a go at those, and then you take them to those past sessions and they help you with that. I don't actually give out the answers to that. And that's so that we're showing the ASAR, our external accreditation body, that we're not spoon feeding you and that you have to actively do some learning. They would question our academic rigor if we were just giving you the answers, and there might have been things that we're testing you on in the tests in those. What am I looking at here on this image?
Obturator internus.
Muscle.
Okay, so the answer actually has 4 words within it.
The left obturator internus muscle.
Muscle, that's right. Because every muscle will have a tendon, and you have to tell me it's a muscle. You have to tell me the full name of the muscle, and you need to tell me, because there's 2 of them there, there's a right and a left, that this is the left obturator internus muscle. Does everyone see that?
Yeah.
Yeah.
These are CT scans, so I've given you a series of these to go through. What am I looking at here?
The right piriformis muscle.
Right piriformis muscle, that's right. Anyone know what this thing here is?
Is it the bladder?
That's the urinary bladder, that's right. We're going to get to that later. What would you say this pointy thing here is that I'm pointing to?
Is it the ischial spine, the right?
That's the right ischial spine. Remember I said spines are like pointy things? Think of the spine of a, I don't know,
Echidna.
or, you know, when they say the, yeah, I'm trying to think, but a spine can be a pointy thing as well. So that's the right ischial spine. That's important because we're going to have ligaments that attach to that. Does anyone know it's going to run, it's a ligament, and it's going to run from our sacrum to our ischial spine, keeping in mind that ligaments are often named after the 2 structures that they connect. So Casey's come through in the chat. Yep. Which one, Casey? Right. So this is going to be our right region of our right sacrospinous ligament. We probably won't really see the ligaments on CT, and I'll point them out on MR. But can you see why knowing the different bits of bone are important? Because they're going to highlight where our ligaments and tendons sit between. What am I looking at here?
Obturator internus.
Right, right muscle.
Yes. So if I, in a test, you said obturator internus, you would get half a mark, not a full mark, because you'd need right obturator internus muscle to describe that structure. Does that make sense?
Yeah.
And that's the way you need to, it's because it's not being pedantic, it's the way you need to describe structures when you're imaging them, because you're going to have different injuries that happen to a muscle that happen to a tendon. So you can have a tear in the muscle or a hematoma in the muscle, but you could have a totally different, you would treat that totally differently if there was a tear within the tendon. And so it has big clinical implications for the patient. And so you would need to describe that structure in terms of if it's abnormal, where the abnormality is happening. And that's why we have to be pedantic about this.
In our exams and that, can we use the abbreviated terms, or do we have to write the full names?
No, if it's a test question, so you're going to have quizzes. The quizzes are just, you have to select an answer, so there's no typing in those. So they're in week 4 and 6. In the tests in week 9 and 13, where you have to type, because they're open book, you have to write the full name out, because someone could Google something and put an acronym and it doesn't show that they understand what it is. That's why. I know it's painful.
Thank you.
But that's the reasoning, and we have to show that. So as I said to you, there's neurovascular bundles. What does the neurovascular bundle contain? It's like a set of traffic lights. 3 things.
Vein, artery, nerve.
Vein, think of it, vein, artery, nerve. So we have we've been looking at these, and you probably haven't even been noticing. In the MR, we're happy that these are our right and our left obturator internus muscles. Can everyone see those? And I pointed out that obturator nerve going through this little obturator canal before. On the MR, can you see a little set of traffic lights, a little set of dots just sitting here? Can everyone see those?
Yeah.
This is a detail that we have to understand in imaging. So that's your obturator, your right obturator neurovascular bundle. So there would be a vein, an artery and a nerve all sitting in there. In what order it can change, and you're just at this point of calling it the neurovascular bundle at this point. But can you see them there and there? And can you see how I said, where does that nerve sit relative to that? What aspect of the obturator internus muscle does that nerve sit? And we said anterior. Can you see how it's sitting along the anterior aspect of this muscle?
Yeah.
Yeah. So I've just drawn a diagram here. This is the femoral head, the greater trochanter. This is the acetabulum. The head and the acetabulum are both lined with a bit of cartilage, which is blue. And this is going to be your obturator internus muscle, which comes around here. And then between the muscle and the bone is the neurovascular bundle. So this is anterior and this is posterior. This is an axial view. This is lateral and this is medial. So I'm talking anterior, posterior, lateral, and medial. Can everyone follow what I'm talking about there?
Yeah.
Yep.
We'll just go on to ligaments and then we're going to wrap it up. We have two, well, sort of three, but two main ligaments, well, maybe three. We have a sacrotuberous ligament. So let's break this name down. It's got sacro and tube in it. So sacro refers to it attaches from the sacrum and tube refers to the ischial tuberosity. Can you see how the ligament is named after the two structures it connects? This is a really important concept that you get early on, because once we get to upper and lower limbs and we have these ligament names that are, you know, feels like you're speaking Welsh, like they're so long, but they're actually really easy to understand. So the earlier you get this concept, the much easier a lot of anatomy will be for you. Sacrospinous ligament, it attaches the sacrum to the spine. You have to know which spine, and it's the ischial spine. Ischial spine is easy because remember both the sacrum and the ischium are more posterior structures. And then we have the sacroiliac ligaments, and they're going to attach the sacrum, this, to the iliac bone, so they overlie that sacroiliac joint. Remember how I showed you the sacroiliac joint, and I said there that joint is, it doesn't look like there's anything in there on CT, but it's stabilized by ligaments that sit in there. So the sacrotuberous ligament's going to run from the back of the sacrum down to this ischial tuberosity, which is this bulky bit. Remember the hamstrings come up onto this. And then the sacrospinous ligament is going to run from the sacrum over to this ischial spine. So I don't know if you can see, I drew these in green on this X-ray for you. Which one do you think this one is here?
Sacrotuberous.
Yep, so it runs in a more of a vertical orientation. And this one here?
Sacrospinous ligament.
And our sacroiliac ligaments would sit up here. They're going to run more along in this orientation. We can't quite see them in this view here. Where would you say your sacrospinous ligament sits relative to your piriformis muscle?
Inferior?
Yeah. So here's our piriformis muscle. Here's our piriformis muscle. This is our sacrospinous ligament here, which I've drawn in here. Can you see how your sacrospinous ligament really sort of sits sort of in between your piriformis and your obturator internus muscles? Sort of starting to get that concept of where structures sit relative to one another?
Yes.
How would you describe the relationship of the inferior portion of the sacrotuberous ligament relative to your obturator internus muscle?
Sits inferior.
Posterior. Posterior.
Posterior. So here's our obturator internus muscle. Inferior to that would be down here. Do you see that? So
Yeah,
this
that
is
makes sense.
inferior and posterior. So can you see it sitting more posterior to it? Can you see how that's the better relative term to use?
Yeah, definitely.
Yeah. And good. Like, it's good to have a go and then go, oh, I see why that's not quite correct, because sometimes working out why it's not correct helps you to understand why the terminology is correct. So thank you for having a go, because it's really important.
So,
So,
Michelle,
yes.
sorry, do we just use the best term, so just one term, or would you refer to
Sometimes you can use multiple. Sometimes multiple are required, because there can be one term's not enough to show the full relationship of it. And you're going to develop that as we go through this. Don't expect to have it by the end of today.
Okay, thank you.
Okay, so I've got some images. As I said, we always show the images from superior to inferior. We've got a series. Are these MR or CT images, do you think?
MR.
MR.
And what plane of imaging?
Axial.
Axial. Excellent. So what bone am I looking at here?
Ilium.
The right ilium.
Right ilium. Yep, the right iliac bone, right ilium. Yep. And what am I looking at here?
Sacrum.
Sacrum. And what do we see between the sacrum and the ilium?
The right piriformis muscle.
Right piriformis muscle. Can we see the sacrospinous ligament on this image?
No, because it's inferior to the piriformis muscle.
Yes. So we can see our piriformis muscle and our sacrospinous ligament. Ligaments on MR, connective tissue doesn't have much water. You know how I said MR shows water? So tendons and ligaments, they're connective tissue and they don't have a lot of water in them. So we tend to have what we call no signal from them. So can you see something with no signal extending between the sacrum and the ischial spine here?
The dark black line sort of thing.
Yep. So signal means there's some sort of brightness to it or some sort of grayness. Because it's completely black, there's no signal. So this would probably be our sacrospinous ligament. It's not big, is it? Ligaments are quite small. They're like usually about 2 to 3 millimeters thick. So it's not easy to pick out. Like you would not look at that and go, oh, there's the sacrospinous ligament, unless you knew that it extended between the sacrum and the ischial spine and that you were looking for something of no signal. We've got a little bit of our obturator internus muscles here. Can you see something just through here? What am I pointing at right there, do you think?
The bundles, nerve bundles.
Obturator neurovascular bundle, and that's right. That's right. So see how now, like at the end of this study group, you're like, actually, I can pick out like millimeter small things out of these MRs that you didn't think you would be able to before, because you know where things sit. Sacrotuberous ligament, so it's going to run down posteriorly. It's sort of in line with the back, or it's at the back of the sacrum, and it's going to have no signal, and it's probably a bit hard to see it here. Can you see something with no signal just here where I've got my arrowhead? Can you see that?
Yeah.
It's not easy. I'm going to point it out and point it out and point it out, and then it
So
comes
that's
onto
the
this
little black bit or the white
it's like
bit?
a tiny little cup thing just anterior to this muscle. Can you see that there?
Yeah.
It's tiny. Once again, it's a ligament. It's about 2 millimeters thick. But if you irritate that and it gets irritated, it can get a lot thicker, and it can become painful at different times. So you can see how small those ligaments are. They're much smaller to see than tendons and muscles and things like that. Doesn't mean they're not important, but they're often overlooked and forgotten because they are so small. There are some membranes. I'm not going to go into that too much because I think I've overfilled your brains today. I think we got through a few little things, but we're developing our thinking. And this unit is all about starting to develop your thinking, starting to get some really basic concepts and apply them to really complex structures. Do you think you're getting ahead? Do you feel okay with the things that we talked about today?
So far, so good.
Yeah. So I think go away, have a look at bones, have a look at some of the labels of those pelvic bones, start to feel more comfortable, think what's anterior, what's posterior, what's superior, what's inferior, what's lateral, what's medial. Look at your muscles, play around with those. Incomplete anatomy. Start to have a look at some images with the images to label and see how you go. And then on Thursday, we're going to go through the levator ani muscles quite quickly. And then we're going to go through some of those neurovascular structures and how we're going to find those on MRs and CTs. So we're going to start looking at iliac vessels and common femoral vessels. We'll look at the sciatic nerve again and the obturator nerve and the pudendal nerve, and we're going to keep it quite simple again. Do you think the type of the tutorial sort of unpacks to a different way? Can you see how it sort of complements the lectures if you've watched them?
Yes, it's still overwhelming, the amount of stuff, but it makes sense.
Yeah. It's sitting, it's like, don't keep thinking of it now. We've had 2 hours of having your brain on. You need to go and see some nature, go outside and have a rest. And then just think of, the main things. We talked about piriformis muscle, we talked about obturator internus muscle, we talked about the obturator neurovascular bundle. We picked the right and the left. We made sure we were using the right complete names for structures, and we picked out a lot of bony things: the ischial spine, the ischial tuberosity, the pubic bone, the iliac crest. Start looking at things like your ASIS and the AIIS. Anterior superior iliac spine, anterior inferior iliac spine, keeping in mind that I'm going to go over those again in week 7 for you, some of those bony things. So we will revisit those because they get a little bit complex. How can we look at them on MRI and CT instead of ultrasound images? Ultrasound images aren't just straight axial, sagittal, or coronal. They're like in all sorts of angles. And if I showed you the ultrasound images of these things, you would give up today.
Just a quick question.
Yeah,
it's just a question.
Yeah.
Do you recommend watching this tutorial again sometime during this week, or like more than once, to consolidate the learning?
Yeah, you'll find that if you've attended it today, you're probably okay, but maybe before, when you're preparing for your quizzes, these things are probably the things to watch.
Thank you.
Yeah, so they're recorded and they'll be up there, and then you can sit there and go, yep, I'm okay with that, I'm okay with that. Oh, I need to unpack this a little bit more myself and sit there and work out the thought process so I can pick it more quickly. But yeah, these are really good for your revision, and you can watch it at much faster speed, and you'll have the PowerPoint, so you may even just need to go through and look at the PowerPoints rather than watch the recording. Okay.
Thank you.
I will let you go. Any other questions? Any other suggestions? Let's stop sharing. Did I miss anything in the chat? Just call out if I've ever missed anything in the chat. You're more than welcome to interject. it does. I think when you look at the lectures, this unit looks very overwhelming, and you've got, if people are only going to look at the lectures and think, oh, I don't need the tutorials and the study groups, and they don't watch them, it doesn't go too well. These things will really help you. Yeah, if you're struggling with the axial, sagittal and coronal, just start going through maybe with your textbook, the sectional anatomy text, and as soon as you look at an image, think, is this an axial, is this a coronal, or is this a sagittal? And then whenever you look at an axial, I'll get these up again. I've lost my, I'll share the,
For you, do you prefer axial or do you prefer transverse as the terminology?
Transverse is probably something we use in sonography. When we're looking at CT and MR, we will use axial. So when we're talking about a CT or an MR image, we're probably going to use axial. Transverse often denotes the plane at which we're holding that ultrasound probe. So it will be like along this way.
Okay, thank you.
Interchangeably. And you'll notice when I get to the upper and lower limbs, I will start using short and long axis, because axial is like a plane of imaging, whereas we will often refer to the long axis of a structure or the short axis of a structure, and sometimes they sit in all different planes. I'm just getting up coronal, axial and sagittal again for you. If anyone has to go and drop out, don't feel like you're being rude. You're welcome to drop out. Can you see this page here? I think I've lost my chat. So axial, you're going to get a cross section through the body, like image like this. So you're going to get anterior and posterior and right and left. Your coronal, you're going to have superior, inferior, right and left. And then your sagittal, you're going to have anterior, posterior, superior and inferior. And you'll see that they will be the labels that you'll have in your text. You'll have S and I, R and L, or you'll have S and I, R and L, and then you'll have A and P on here. Does that make sense? And
yes,
that's going to help you work out. And then the text will also should tell you if it's a sagittal or an axial or a, I think, or a coronal. I think they probably use axial views because that's the terminology we use for CT and MR. And you think, oh, why are we doing ultrasound and we are only looking at these images? It's too abstract for you to get your head around ultrasound images at this stage. Please believe me. Yeah, it's not that I'm trying to hide them from you. It's just far too abstract. And these images show more of a bigger picture. Often the ultrasound images will show you just a little structure, and you're like, I can't tell what's anterior or posterior, superior, inferior in those. And you've got to start developing thought processes at the start. I promise you, there's reasoning behind it. Yeah. Okay, I will let you go. If anyone's got any questions.
Sorry, Michelle.
Yeah.
Thank you. I just wanted to ask, now with Thursday study sessions, will they be recorded by any chance?
Yeah, both of these are recorded. Yeah,
all right, beautiful.
These are recorded. So if you miss one or miss part of it, they're all recorded. Because those medical images have really big files, and you can see how many images I put into the PowerPoints, they take a while for the recordings to render because it depends on your file size, the video and the images. So they take a lot longer than other tutorials you might have where someone's just got words on a PowerPoint, and these go for longer as well.
All right, thanks, Tips. Appreciate it.
When they're done, they get uploaded. It just depends on the file size, really, of how many images I've got in there.
Awesome. Thank you so much. It's definitely made it a lot easier to picture and understand.
Yeah. You're going to the ultrasound and medical imaging, you end up, everything's visual. So you end up becoming, even if you're not a visual learner, you become a visual learner because it's pattern recognition and things like that. So we slowly, softly develop some thought processes so that you don't get too flustered as well, and you go back to very basic thought processes rather than when you get that flustered feeling, you don't think properly. I'll let you go. Have a nice rest of your day, and I will see you again on Thursday.
Thank you.
That's
Bye.
Okay. See you. Bye.
Thanks, Michelle.
Bye. I'll end it for everyone, and I'll see you all later. Any questions, post them in the forum. See you.